very good morning, and we'll be starting our course in a couple of minutes. Our course is called Deconstructing Reconstruction. That's a comprehensive course on eyelid and ocular surface reconstruction. So, we have some eminent speakers with us who will be taking us through the reconstruction of the eyelid and the ocular surface, and how to harvest grafts and various principles will be covered. So we have Dr. Aman Vaishya first. Dr. Aman is pursuing his fellowship at Vision Eye Center in Delhi, and he'll be talking about the principles of flaps and grafts.
Good morning everyone, I'm Dr. Aman Vaishya. I'm a fellow at Oculoplasty and Ocular Aesthetic Services at Vision Eye Centers, New Delhi under Dr. A.K. Grover sir. I'm extremely thankful to Dr. Rwituja ma'am and Dr. Grover sir for giving me this opportunity to share the dais with the stalwarts in the field of ophthalmic plastic surgery. I'll start with my presentation on flaps and grafts now. So we'll be covering the presentation under the following heads. So what are the basic goals of reconstruction? The basic goals of reconstruction are basically for the functional rehabilitation and the cosmetic rehabilitation. What is the reconstruction ladder? So this is a very important concept which is followed by all the reconstructive surgeons around the globe, and it is a 4-step process which involves direct closure, which involves suturing and the healing with secondary intention, autologous skin grafting, which involves split thickness or the partial thickness skin grafting, followed by the loco-regional approach which includes the pedicle flap, and final stage being the free flap. So coming back to the basics, what is the difference between grafts and flaps? So graft is a tissue which is harvested from a donor site which does not have its own blood supply, and it depends on the recipient site for its blood supply. On the contrary, flaps are the tissue which are harvested and they carry the blood supply on their own. Important differentiating feature is cosmetically, grafts may discolor or contract, but flaps, they have a better color uptake and less likely to contract. So what is the basic principles of reconstruction? We need to restore the like tissue for the like. Remember the basic principle: graft when laid on a flap, flap when laid on a graft, and flap when laid on a flap. All three have a very well post-operative outcome, but a graft on a graft reconstruction has a high failure probability because of the lack of the vascular supply. Coming on to the relevant anatomy. So we'll be covering it under the following heads of external eye examination, relaxed tension lines called as a Langer's line, and anatomy of the eyelid. So this is a diagram showing the horizontal palpebral aperture which measures between 28 to 30 mm lying between lateral canthus to medial canthus. Vertical palpebral aperture, also called as the palpebral fissure height, is somewhere around 9 to 10 mm. So this is a slide showing the anatomy of the eyelid. So the major differentiating feature between the upper eyelid and the lower eyelid is the presence of the capsulopalpebral fascia in the lower eyelid, which is replacing the LPS muscle present in the upper eyelid. The most important concept being a reconstructive surgeon is the presence of the gray line, as we all know, which is the junction of the skin and the conjunctiva. It divides the intermarginal strip into the anterior lamella, which is nothing but bearing the skin and the eyelashes, and the posterior strip, which consists of the opening of the meibomian glands. Now this is a slide showing the relevant vascular supply around the orbit. Important is the presence of the superficial temporal artery, as one of the named island flap is based on this superficial temporal artery. What are Langer's lines? So these are the relaxed tension lines. These are the preferred direction of the skin incision in the facial region. They lie parallel to the natural orientation of the collagen fibers in the dermis. They forms an aesthetic scar and avoids the gaping whenever the incision is given along these lines. Now, assessment of the eyelid defects to be reconstructed. In our clinical scenario, we can have an eyelid defect which can arise either from the traumatic setting. In the second image as shown is the congenital coloboma, and after the iatrogenic cause like the tumor resection. Sticking to the nomogram for the lid defect affair as being practiced around the globe by all the reconstructive surgeons, lid defects can be classified as either the full thickness margin involving defects or only the interlamellar defects. Interlamellar defects, depending on the size of the defect, can be closed either with the primary closure or by the skin grafting and the flaps. On the other hand, full thickness margin involving defects can be again further classified on depending on the amount of the tissue loss as small defects, medium sized defects, or the large defects. What are the common grafts in the ophthalmic plastic surgery? These are the skin grafts, which can be full thickness or partial thickness, cartilaginous grafts, including the hard palate grafts, mucosal grafts, amniotic membrane grafts, and composite grafts. So sticking to the basic principle of stages of the graft uptake, so this involves basically 3 stages. That is the imbibition stage, which is lasting for 24 to 48 hours. Second stage is inosculation and capillary ingrowth stage, which ends in about 48 hours. And the final stage being the revascularization stage. So importantly, a graft needs at least 4 to 7 days, and only after that we can tell about the outcome of the graft procedure. So coming to the skin grafting, it can be divided as full thickness skin grafts or split thickness skin grafts. In ophthalmic plastic surgery, eyelid reconstruction, better suited is the full thickness skin grafts. And this is the image showing what are the common sites we can harvest the grafts. It can be a contralateral eyelid skin from the preauricular or the postauricular area and the supraclavicular area. Now coming on to the next is labral mucous membrane grafting. This is done in cases of inferior eyelid retraction associated with lower fornix contraction. The important point to ponder is we need to harvest the graft at least 1 centimeter away from the vermilion border to prevent the scarring and contracture of the lip. Hard palate graft, this is the type of cartilaginous graft. Important site for the graft harvesting is the canine premolar area, which is approximately 8 to 13 mm from the mid-palatal aspect. Going beyond 13 mm will lead to a damage to the increased risk of neurovascular bundle damage for the greater palatine. Coming on to the flaps in the ophthalmic plastic surgery, the common flaps that we are using in ophthalmic plastic surgery are advancement flaps, transposition flaps, sliding flaps, and the rotational flaps. Flaps can be classified based on the location as local flaps or distant flaps, based on the blood supply as random pattern or axial pattern. Important is in random pattern, the vascular supply is lies on the rich subdermal vascular plexus, while in axial pattern it is directly from the direct cutaneous artery. So what are advancement flaps? In this, the surrounding skin is fashioned into a 3-sided flap, which is dissected and advanced on its long axis to close the adjacent defect. Important is the length of the defect to the flap ratio is preferably restricted to 1:3. In rotational flap, these are the flaps which are commonly used in the periocular area, where the directly adjacent skin is lifted over the intervening skin and fitted into the defect. What are transposition flaps? Transposition flaps in this, the skin is not directly adjacent to the defect area, but the intervening skin is lifted and rotated along its own angle. But the important thing is the angle should not be large enough, as it may compromise to the vascular supply. So what is the tensile advancement flap? It can be seen from this image. This is done either for the lower eyelid or the upper eyelid defect, in which we create a semicircular incision and advance the skin for the skin closure. This is the image showing the Cutler beard, which is the bridge flap for the full thickness advancement flap. This is done commonly for the upper eyelid defect in case of iatrogenic causes. Coming on to the next is Hughes tarsoconjunctival flap. This is done for the lower lid iatrogenic causes, in which the posterior lamella is taken from the upper lid tarsoconjunctival complex, and the anterior lamella is made with the help of the postauricular graft area. So what are the common named pedicle flaps in the ophthalmic plastic surgery? Image 1 shows the Fricke's flap. Image 2 is paramedian forehead flap. Image 3 is eyelid, lower eyelid to upper eyelid transposition flap. Image 4 is nasojugal flap. Image 5, also called as the bipedicle or the bucket handle flap. And image 6 is the islandized superficial temporal artery flap. So I'd like to conclude as what are the different options for free grafts and flaps available, both for the anterior and the posterior lamellar reconstruction. Thank you.
Thank you, Aman, and thank you for finishing on time. So basically, you've covered each and every aspect of the principles of harvesting of the flaps and the grafts, and now we'll go into detail about handling each type of reconstruction of the eyelid, starting with Dr. Akshay Nair, who's a prominent oculoplastic surgeon practicing in Mumbai, India, and he'll be talking about managing upper and lower eyelid retraction, which is a difficult scenario for many oculoplastic surgeons to handle, and there are various ways to handle it. So we'll get some insight from him on that.
Thank you so much, and I noticed how the previous speaker spoke about harvesting mucous membrane grafts, hard palate grafts, all of which is amazing because that covers a lot of the surgical technique of what I'll be talking about in terms of. Okay, एक second. Yeah. So lid retraction. So I've divided this broadly into two topics: upper lid retraction and lower lid retraction. There can be many causes of upper lid retraction, and the most common, of course, being thyroid eye disease. Pseudoproptosis or proptosis can also give the appearance of lid retraction purely by the physical outward projection of the the eyeball that gives the illusion of lid retraction. Post-surgery can be another cause where, because of surgical correction to the superior rectus, the ptosis overcorrection, and rarely myasthenia, paradoxically, and hepatic failure are systemic causes. We'll come to contralateral ptosis as a cause of proptosis or pseudoproptosis in the other eye. So enlargement of the globe, especially in axial myopia, unilateral axial myopia, or true proptosis by outward protrusion of the globe because of a retrobulbar mass, pushes the upper lid up and is also associated with lower lid retraction. So in cases where you're unsure or you feel that there's some amount of proptosis, it's always a good idea to get an exophthalmometry done. Now, thyroid eye disease lid retraction is commonly associated with the classical lateral flare. Now, in this patient, you can see that in the left eye, you have a more typical lateral flare. The lid retraction is clinically visible by the scleral show that you see superiorly, where typically the lid should rest 1.5 to 2 millimeters below the upper limbus, but here instead it is resting 2 millimeters above the limbus. The lateral flare occurs because in thyroid eye disease there is initial scarring of the fascia between the lacrimal gland and the levator muscle, which is present superolaterally, causing a superolateral lift in the eyelid, giving it the classical flare. Whenever you see a patient with thyroid eye disease, it's important to work up and assess the endocrinological status of the patient. So get a free T3, T4 TSH done, as well as thyroid receptor antibodies to understand what phase of thyroid eye disease that patient is in, because that will also help you decide what other treatment needs to be done. If it is an active disease, and the patient has an active clinical score of more than 4, you should actually go ahead and treat the patient with immunosuppression to correct the orbital and the eyelid component inflammatory phase of thyroid eye disease, as well as address the symptoms in terms of lubricating drops and other methodologies to address the surface related issues. And finally, deciding when to operate. You can either operate it once it is in the burnt out or in the inactive phase, or you can plan it later on if there are other surgeries like decompression needed. I prefer to treat thyroid eyelid retraction in the inactive phase or the burnt out phase. Rarely in the active phase, if a patient presents with isolated lid retraction, you can also go in and treat it with injections. So this is not a hard and fast kind of a rule. This is more of what I follow. If it is mild eyelid upper eyelid retraction, an intralevator steroid, either with triamcinolone acetonide, 5-FU, or additionally using 5-FU and botulinum toxin can be given. Now, mild is where the upper eyelid rests at the limbus, as you can see in the top picture. Moderate would be where it is about 2 millimeters above, and severe would be where it is more than 2 millimeters above the upper limbus. In moderate, one can either do a muellerectomy or a full thickness blepharotomy, and in severe thyroid retraction, you can do a complete blepharotomy with or without a spacer graft to be placed to increase the width of the length of the posterior lamella. So now in upper eyelid mild thyroid related retraction, I like to give an intralevator or subconjunctival steroid injection, which is mainly given at 2 points. 0.5 ml along with is injected in 2 aliquots at the mid-pupillary line and lateral to address the lateral flare if there is any. You place in a Demar retractor and flip the upper eyelid. It can be a little difficult in patients who have thyroid eye disease because of the tone of the Mueller's. Put in a drop of paracaine and under topical anesthesia just above the tarsal edge. You go in subconjunctivally and inject into the Mueller's and the levator muscle. It works by 2 ways. In active disease, the steroid reduces the inflammation and the overactivity of the Mueller's muscle. And additionally, by stretching out the conjunctiva and the molars and the levator and the attachment to the tarsus, it physically and mechanically stretches it. Now, in burnt out disease or in inactive disease, adding a little 5-FU helps to modulate the levator stretch that there is, the scarring that has set in, and can help in releasing well. It, of course, in burnt out cases, you may need more than 2 or 3 injections as well. So in moderate upper eyelid, I also again prefer the same technique. Only thing here is that I like to add about just 1 unit of botulinum toxin, which adds to the neurogenic component of bringing the eyelid down. And once it is down, the stretch effect of the depot steroid that you've injected acts for a little longer. Only thing is that in moderate disease, again, like burnt out lid retraction, takes 2 or 3 injections, and I prefer to add 5-FU in all these cases. So it's 0.5 cc of triamcinolone and 0.5 cc of 5-FU, and then inject 0.5 cc of this mixture. And finally, in severe thyroid eye disease related retraction, I can do a muellerectomy or full thickness blepharotomy, which can be graded based on the severity. The full thickness includes an incision through the lid skin, the orbicularis, and at the upper edge of the tarsus, separating the attachment of the levator or the molars with the tarsus, and creating an open space where one could even add a spacer graft, and done under local anesthesia. There are many papers that have shown this to be a very predictable technique. This is how I like to infiltrate. This is a picture of a case which was operated by Dr. Milind Nayak at LV Prasad. This is dissection done subcutaneous through the orbicularis, isolating the tarsus. That structure that you see here is the tarsus, above which is the molars, and you can see the radiofrequency cautery tip has begun creating a full thickness blepharotomy. Now the blepharotomy is continued till there is just a small central attachment, and the lateral horn should be disinserted, especially to address this lateral flare. Check intraoperatively the amount of correction that you want. Over correction with the lid 2 millimeters or 3 millimeters below the limbus is ideal, because believe me, even after a full thickness blepharotomy with no attachment to the tarsus, the tone of the molars and the levator is so much that it brings up the eyelid even in those cases. No suturing the conjunctiva, but definitely suturing the orbicularis back and the skin back in continuous. And these patients do really well. This is a patient who had both eyelid retraction, upper eyelid retraction surgery done with a blepharotomy. And you can see that even the eyelid scars have healed well. Again, another patient, bilaterally done, operated. This is a unilateral case. The only case that in some cases the pre-tarsal show may not be ideal and matching, and you may need to do a subsequent surgery to get a symmetry of the lid crease. So this upper lid surgery can also be done in combination with thyroid surgeries, where it can be combined with a lid crease incision when you're doing a decompression. However, lid position may not be predictable, as it can come down because of the decompression of the orbit, so it can also be staged. Lower lid retractor release can be done at the time of decompression. So now that takes care of upper eyelid retraction. I'll come to lower eyelid retraction. Now lower eyelid retraction, cicatricial ectropion because of scarring of the anterior lamella are on the same continuum, but I'll not be speaking about cicatricial ectropion, which in itself is a separate topic. I'm going to talk more about lid retraction because of posterior lamellar or middle lamellar related issues. Now lid retraction in the lower lid can either be age related, which is very subtle and due to gravity, or it can be post-surgery, typically surgeries that violate the lower lid retractors, like a blepharoplasty or a fracture release. And it can also be post-trauma and post-thyroid eye disease, like we already know. It's a little bit important to know the 3 lamella, the posterior lamella, which is the tarsus, the lower lid retractors, and the conjunctiva, and the anterior lamella, which we know is the skin and the orbicularis. The middle layer, or the middle lamella, which is now more like a functional rather than a structural entity, is the orbital fat and the septum. And adding volume here is a very, very good important part. One thing to do whenever you see a patient with lower eyelid retraction is to do a forced eyelid traction test, where you take your fingers, place it at the edge of the lower eyelid, and pull it up to see how far up it goes. Now ideally your finger should be able to reach the upper lid margin, and completely close the eye. You can actually try it yourself. But if you feel any kind of limitation, that gives you that this is a positive forced eyelid traction test, and there is a posterior lamellar contracture that needs to be addressed. Now, age-related lid laxity and canthal laxity can also cause some change here. You can see in the left eye especially that the lower lid had descended down and you have a little inferior scleral show. This can be addressed by a simple lateral canthal tightening. I just have 6 more slides. I'll complete that. Post-surgery, especially post-blepharoplasty, post-fracture repair, orbital surgery, these cases can have lid retraction, and either too much of the fat or the septum has been violated, causing it. So this was a patient who had middle lamellar scarring. Now, on the face of it, it may appear that skin graft is needed, but actually a skin graft was not needed because skin was not actually excised. So what was done was lower lid filler was given, and with the filler, the stretch effect, the middle lamella was augmented with volume, and that gave a good correction. Now again, this is a patient who had a trauma. You can see the lower eyelid, there's a fracture, there's a titanium mesh placed, which has caused the scarring of the posterior lamella, leading to eyelid retraction. Again, a tear trough hollow with a little filler in the lower lid, although I think he could do with a little more filler, and that has helped to bring up the lower lid retraction. Post-blepharoplasty, this is asymmetrical lid retraction, and a hard palate graft was placed. Look at the right eye, the lower lid is 2 millimeters below the limbus in the right eye, and we added a hard palate graft. The place to add the hard palate graft is at the lower border of the tarsus, which is then reattached to the lower lid retractors or the orbital, the capsulopalpebral fascia. Another case, this is a patient who had significantly more scarring after a cheek implant, which was done outside. And the patient came back and had this kind of a picture. He said his eyes were appearing droopy, so a hard palate graft was put. Some patients, they come to you with no surgery, no trauma, no thyroid eye disease, and they just say that they want the eyelid has gone down and they need it to be done. So that's what we call a cosmetic lower lid retraction. You can augment these cases with a canthopexy. This patient actually had an upper eyelid blepharoplasty, has lid crease asymmetry, but wants this lower retraction to go. Sometimes you wonder and look at the patient and say, what lower lid retraction? It's hardly visible, but it's there. That's the lower lid retraction, 2 millimeters. In these cases, all you need to do is an isolated lower lid retractor release with an upper lid frost suture, lower lid frost suture for a week that stretches out the posterior lamina and corrects it. Thyroid eye disease lower lid retractor, isolated lid retraction without proptosis can be corrected again with a lower lid retractor release along with an extreme lateral tarso or a canthoplasty. You can also address the upper lid at the same time. My last slide, this is a patient who came to me, had ptosis, and this was the picture, and another surgeon in a different city had advised levator resection with canthopexy. Now, the reason why this patient has apparent lower lid retraction is because of the ptosis. The mechanism here is that because of the ptosis, the there is an inherent drive to lift the upper lid. The upper lid is lifted by the levator, and apart from the active lift on the levator, the patient also has an inactive or a passive reduced tone of orbicularis, because the orbicularis is the muscle that closes the eye. So when the levator is trying to lift, the opposing muscle orbicularis also loses its tone and reduces its activity, and therefore there is the apparent lower lid retraction. He underwent a ptosis surgery, and after the ptosis surgery, the lower lid automatically comes back into position and is symmetrical. So to summarize, lower lid retraction can have many causes. It's important to identify and address the cause based on the severity. Do not forget the canthus while addressing the lower lid, especially in older patients. Fillers and scar modulators, by adding volume to the middle lamella, can buy you time or even treat the actual cause. Timing is important in thyroid eye disease because you need to make sure that you do not operate when it is active or end up having more complications. Thank you so much.
Thank you, Dr. Akshay. That was a very comprehensive coverage of the topic. I think it's interesting that you said that lower lid fillers can buy time, because we had a similar patient who had a surgery done for squint inferior rectus surgery, after which she developed some amount of lower lid retraction, and she had some pre-existing mild ptosis as well. So the checking for the tightness of the lower lid is again important. So there was a little bit of tightness, so we had to put in a filler temporarily for an event for her. But later on, we had to go in and do a hard palate graft to definitively correct it. So, anything else that anyone wants to add?
Sure. Thank you.
So when we talk about upper lid retraction in TED, blepharotomy, yes, it's a So would you prefer blepharotomy or the LPS recession as a surgical modality for the upper lid retraction?
So I think they just they pretty much go hand in hand, except that in an LPS recession, you actually have to open up the septum to reach the levator. And yeah, I think, at the end of the day, by disinserting the Mueller's and the conjunctival attachment on the tarsus, obviously the levator is also being disinserted. But yes, in a recession, you actually go up and displace the levator further up. So I think in those cases, in the more severe they are, I may have to add a levator resection. But now over time, I find that levator recession is a little less predictable in my hands. So I either prefer a blepharotomy or a blepharotomy with a spacer.
Thank you.
Thanks.
So next I'll be covering fascia lata graft, basically how to sow, harvest and reap, that is how to take the graft and perform the surgery. So how do we decide when to do a frontalis sling surgery? Of course, we all know that when you have a very poor levator action, that is less than 4 millimeters, that's when we decide to go ahead and do a frontalis sling surgery. So we have various materials which we can use, that is autogenous or synthetic. Amongst the synthetic, of course, the most commonly used is the silastic sling and the ethibond in younger children. And the fascia lata sling is something that we do for severe ptosis, and now there's a frontalis flap which is also done for the same. So when there is a poor levator action, of course we go in for this surgery, but fascia lata is preferred especially in bilateral cases such as these, that is in blepharophimosis. Now, with severe bilateral ptosis, you can also opt for a frontalis flap surgery. However, it's been done in the recent years and it doesn't have too many studies yet on how it does in the long term. Now, some of the disadvantages with a synthetic material is that it can drop after a few years and needs tightening. So it's important that when we counsel patients for a silastic sling, we tell them right at the beginning that you may need an adjustment or a recorrection later. So this is always a temporary surgery. You can have an infection or a granuloma or an exposure because, of course, you may bury the knot as deep as possible, but in children, they may tend to pick at that area and cause some amount of exposure. So the good thing about fascia lata sling is, at least I haven't seen any reactions or granulomas. I think Dr. Grover can comment on his long-term experience. It gives an extremely good contour. It gives you a good lid crease as well. And we haven't really seen any worsening with time. So the technique that we use is a Crawford's technique, wherein you see this double triangle, which is pulled up again with the 3 incisions above the eyebrow. And this is how we mark the patient. So this is a patient who had already undergone some amount of telecanthus repair, and we had planned a bilateral fascia lata sling for him. So fascia lata doesn't really need any complex instruments such as strippers, etc. You can do it with a small incision on the thigh such as this. So, and you need to harvest a graft which is around 15 to 20 millimeters in width, so that you get about 4 or 5 strips. Now, where do you mark the incision? It's about 4 finger breadth, depends on how thick your fingers are, but around 4 finger breadth from the lateral tibial tuberosity. And you can make an incision which is about 2.5 to 5 centimeters long, depending on how skilled you are at getting this graft out. Now, the main best way to get the graft out is, once you've reached the fascia lata surface, you go in with a finger dissection. So you release all the attachments of the thigh with your finger, go in with a loop as well as an external light source, and you can see deep inside the thigh in order to harvest this length of a graft. Now, the graft has to be cleaned off. All the fat and all the other material has to be removed from the graft so that it's a glistening white band. And once you've divided the graft into 4 or 5 parts, one part is just an extra part in case one of the strips breaks, you go in with a Wright's fascia lata needle. So you can see how you go through this top incision. You put it down through the incision on the eyelid, and this is a eyelid crease incision which we've made to excise some of the excess skin. And then you go ahead and put in your graft through the Wright's needle and pull it out of the incision through which you've entered with the needle. So this is how it would be once you've passed it through the eyelid and through the, once you've done the double triangle part of it. And then some people don't do this passing it through the upper incision, but it's better that way. It kind of has a longer stability. So once you've passed it through the 2 incisions at the eyebrow, you can then go ahead and pass it through the upper incision and tie it off there. It's important to secure the knot with a 5/0 vicryl suture and have a nice 2-layered closure of the thigh as well, because even though this is just a single incision, you can have some amount of gaping. So it's important to remove the sutures alternately at the first week and then remove the rest of the sutures after 2 weeks. So a fascial lata sling surgery isn't as difficult as it looks. It's basically harvesting the graft properly and then going ahead and passing it like any other frontalis suspension surgery. So I'll just forward this video to the part where we're harvesting the graft. So this is the incision which we make. You go ahead and dissect through the dermis and through the fat. And once you find the fascia lata, you go ahead and open up the bit of tissue which overlies it. And you can straight away go in, if you have people retracting on either side, go ahead and excise it, clean it off like I mentioned. And then once you've cut it into strips, you can pass it through each of the incisions to give a very nice contour. So the other thing which goes to give a nice contour is, of course, dissecting all the incisions well. So dissecting the 2 eyebrow incisions on the lateral sides 360 degrees gives a very good contour. And at the end of surgery, you can have very gratifying results such as these, where a person who has severe frontalis overaction, all that is abolished after surgery when you open up their visual axis. So I'm showing this picture just to show you how you should take care of the patient after surgery as well. You put in a nice frost suture because, of course, in any congenital ptosis, you can get exposure when you correct these patients. And these give a long-lasting contour, a very nice result. And of course, there is some amount of lag of thalamus, although it's debatable whether it is less lag of thalamus than a silastic sling or not. Now, in blepharophimosis, like I mentioned, it again has long-lasting results. But the main point of doing this in blepharophimosis is the fact that you're abolishing the frontalis overaction and you're giving them a lid crease. So these are some of the cases. Now, the issue with this is sometimes you can have lid lag, but if you do a bilateral surgery, it would be a symmetric lid lag, so the patient won't really complain, and that the lag of thalamus is minimal. In some cases, you can have an undercorrection. Overcorrection is very rare, and you can have a poor contour very rarely in this procedure. So, in children, it's again a debate that can we do it in children below 4 years of age? Yes, you can actually do it below 4 years of age as well. And when you compare it with a silicone rod, the repeat surgery rate is slightly more with the silicone rod, but the main thing is that the results are comparable. So if the patient is okay with getting an incision in their thigh, you should definitely go ahead and do the frontalis suspension. So doing a frontalis link surgery, especially in patients with blepharophimosis, really improves their confidence and gives them the ability to face life with a slightly more normalized appearance. Thank you.
Shown. The one aspect I would like you to highlight is where would you choose a silicone rod or where would you choose a fascia lata?
Yeah, so like I mentioned, the fascia lata would be ideal in bilateral ptosis. The silicone sling is probably ideal in unilateral cases of ptosis. And also in these syndromic patients, bilateral is more preferred because you can go ahead and take one graft and do the surgery on both the sides. A silicone sling again is required in very young patients as well, where there is a severe ptosis which is probably amblyogenic, wherein you need to go ahead and do an urgent surgery, especially when they are less than 1 year, when you need to clear their visual axis. So even if it's bilateral in those conditions, you'll need a silastic sling for that. Yeah, so in myogenic ptosis, again, once the disease has sort of been there for several years, going ahead and doing a frontalis sling, either way is fine, but a silicone sling is something which is slightly better in those conditions because you can't really reverse a fascia lata graft that well, whereas if there is a motility restriction, it's better to do a silastic sling because then there is a possibility that you can reverse it as well if you're finding any exposure or anything like that developing. Yes.
Similarly, in those cases which are traumatic, unless the canthi are fixed well, your results are very poor. You get to
Yeah.
Okay. Yeah, my question is blepharophimosis again. So as you said, canthoplasty and then it give a good contour to the upper lid. Would you do it in the same sitting, the canthoplasty and the lift?
Only in cases where I'm not doing a transnasal wiring. So if there is a great horizontal stretch, then I would not do it. For the milder, moderate cases where I'm only doing a medial canthal ligament tucking, I would go ahead and do some cases.
So in all of the cases which we showed, these were all patients who had them done after about 6 months of telecanthus repair or lateral canthus creation. So next we have Dr. Ashok Grover. He of course needs no introduction. He's going to talk about eyelid reconstruction and cover each and every type of eyelid reconstruction.
Thank you, Rituja. Thanks for this wonderful course, and it's a privilege to be working together. She's an excellent surgeon and an excellent human being. So eyelid defect management, we'll talk about indications, principles, evaluation, management of non-marginal defects, full thickness defects, flaps and plasties, Aman has covered well, and canthus reconstructions. So the acquired eyelid defects may be because of this, most commonly because of the surgical resection of eyelid tumors, but we also see them. We also see them following trauma or following previous complicated surgeries. We used to see them often after entropion corrections, multiple entropion corrections early. So what is to be remembered is that eyelid is constituted by principally two lamina, the anterior and the posterior. The anterior one constituted by anterior covering of skin and the orbicularis oculi, and the posterior one with the conjunctiva, tarsus, and the levator emulus complex. So whenever we do an eyelid reconstruction, we have to think of reconstruction of both the laminae. At least one laminae, if it is with a vascular supply, it's a great help. The other lamina may then be a free graft which can derive its vascular supply from the other which has a pre-existing vascular supply. So for your decision making of management of eyelid defects, you need to see whether it's the upper or the lower lid being reconstructed. The principles and the importance differ. It is more desirable to do a lower lid, an upper lid reconstruction with a lower lid reconstruction, but if lower lid reconstruction using up the upper may at times be a little controversial because you are using the more important eyelid for the purpose, but in most cases we do go ahead without any difficulties. Then you need to have different techniques for superficial or deep defects or full thickness defects. Those that involve the margin require different techniques. Different sizes of defects may require different strategies. And the shapes of defects will also determine the kind of reconstruction that you do. And at times you would like to convert the defects to the shape and size that you want. Now, we'll divide the full thickness defects into 1/4, 1/4 to nearly 2/3 and near total defects, and then we'll talk about the canthal defects. For the non-marginal defects, the principle is along the Langer's line or along the tension of the orbicularis muscle fibers. So, principally parallel to the lid margin as we've done here, and closure. So, the upper lid, this principle always holds true, but in the lower lid for defects like these, we would prefer to make a vertical cut in order to avoid any stretch on the lid margin to avoid an ectropion. But the defects that are larger, you must use flaps or grafts in order to reconstruct. Now this is an example where a partial thickness graft, partial thickness lid defect is created once the kissing nevus is removed, and you can replace it with just the anterior lamella so that you can preserve the margin and the medial canthus well. I'll skip the flaps, which Aman has covered so well. So let's go on to the full thickness eyelid margin defects. The smaller defects are amenable to direct closure, especially in the older subjects, and particularly when they are combined with the lateral canthotomy and opening up of the attachment of the eyelid to the lateral orbital margin through the canthal ligaments. If cantholysis is also combined, you can go ahead and probably do a 30 to 40% closure. An example is a basal cell carcinoma here with a zone of about 4 millimeters, and this, being an older subject, is amenable to a direct closure. We'll look at the technique of direct closure. I prefer to do the first suture just behind the gray line through firm tarsal plate with a vertical mattress suture. 60 silk is my material of choice because it's more supple and would not cause irritation to the globe. And then once you oppose the lid margins after the first suture you already have an apposition, but you would like to get a better apposition closer to the posterior margin to retain its capillarity and anteriorly for aesthetic reasons. So similar vertical mattress sutures are passed, the first bite being about 3 millimeters away from the cut edge, 3 millimeters depth, and the second return bite 1 millimeter from the cut edge and 1 millimeter depth. So all these 3 sutures are left long, and the posterior 2 sutures are tied within the anterior most suture to keep these sutures away. And then a good closure of the posterior lamina is also important. So we take partial thickness tarsal bites with a 5-0 Weichel suture. 2 or 3 sutures would oppose it well, and then the skin closure may require a bit of removal of dog's ear to get a good apposition, and closure is carried out with everting sutures. So the defects that are larger may require other techniques both for anterior and posterior lamina. So skin flaps such as trippiers or freaks, which were spoken about by Aman. Tenzel's lateral semicircular flap, which we'll talk about, and lid sharing techniques are often used. We'll go through the Tenzel's repair. This was a congenital coloboma, so we had to convert it into a pentagonal shape. A freshening of edges is also required because it is a congenital defect. And once you have the desired shape, you can draw the area of the semicircular flap. It goes down and reaches up to the orbital rim for upper lid and the other way around for the lower lid. And then we are doing a cantholysis, as you can see, under the conjunctiva, going up to the lateral orbital rim, releasing it, undermining the skin flap, making sure the lateral canthus is totally free, and then looking at the remaining conjunctiva and be doing the marginal repair as we had done earlier. And then, of course, the skin closure. And then it is important to reconstitute the lateral canthus. So you can pass a vertical mattress sutures, or you can take the marginal sutures as we did earlier in order to create the good lateral canthus, which is again lateral angulation is important. Then we close the skin, and then we also make sure that we have not allowed the lateral fornix to become shallow by passing a double arm fornix creating suture. So what are the advantages of the lid shearing procedures, which we'll now talk about? The eyelid tissues would provide a good match. They often can give you both the laminae. A procedure like a tarsoconjunctival flap is an extremely versatile flap which can be used for lateral canthus, medial canthus, upper lid, lower lid, and over a period of time, the tissue stretch takes care of any shortcoming that you may have created, but you of course need to avoid them in young children, and if there has been any previous surgery or trauma in the other opposite lid. Tarsoconjunctival flap technique, as we said, or hues modified in different ways, is a very useful technique. We can look at this last video, I think, and this was a sebaceous carcinoma excised with a zone around and then subjected to frozen section. This is a 4 millimeter zone we have gone by at this stage. And this is the defect, and the frozen section did show some involvement, so we sent in another one and waited for the report, and then we went ahead with the repair. Here we are taking a tarsoconjunctival flap from the lower lid, leaving the 3 to 4 millimeter zone near the margin to retain the intact vascular supply, and then we go ahead and repair the posterior lamina completely by suturing with a 5/0 vicryl, and then anchoring the flap on either side. And then here we realized that we could use the skin which was adequate, and we could use it as a flap from the upper lid itself, and we used that for reconstruction of the anterior lamina. This shows the second stage, where the important thing is to leave adequate extra conjunctiva to constitute the margin by using that as a flap to come anteriorly rather than the other way around, so that you do not in the long term have any lanugo hair touching the cornea. Reconstitute the canthus and do a skin closure well. Now this is a bulky lid initially, but then it gradually opens out as the lymphedema decreases and gives you an adequate closure. So this is an example of a lower lid carcinoma where we've done an excision with frozen section control, and lacrimal passages had to be sacrificed. We've used a tarsoconjunctival flap from the upper lid here, and also used a trippier flap for the constitution of the skin. The cutler beard was explained by Aman fairly well. We have spared a 4mm bucket handle and then drawn the two flaps to suture the anterior and the posterior lamina, opened at the end of 6 weeks for deconstruction. For even larger defects, then you need other techniques both for posterior and anterior lamina. The flaps which are used are the glabella or a midline flap or a temporal forehead flap, and then you need a posterior support as well. Mustardase flap is less often used because it's fairly large mobilization with scars. So a firm support for the internal lamina is also important when you're creating a large defect. So a free tarsoconjunctival graft is often used, but tarsoconjunctival flaps for the relatively smaller defects work well. So the periorbital flaps, we'll see some examples here. This is a superficial temporal artery-based flap. Tarsoconjunctival flap combined with a superficial temporal artery flap. So many of these defects require combination of techniques. Like this lady did not want a surgery for a long time, 7-8 years she had waited. But when she learned the cost of the biologics, she preferred me to biologics. So at this stage, it was a tough job. Whole of the upper lid, virtually entire lower lid, and the medial canthus had to be sacrificed. And then we had to do a midline flap, which we divided into two to carry out a reconstruction in the medial canthal region. Used a nasal mucocartilaginous graft and had to combine it with a free skin graft as well. And we ended up with something like this early. This was at 3 months. Of course, she didn't want a second surgery. We were trying to persuade her to improve her appearance. Wasn't convinced. Lateral canthal and medial canthus are the two other important things. So the principle of lateral fixation of the firm tarsus at the lateral orbital rim with sutures that go from the double arm sutures of material like proline, which is permanent, or even vicryl sometimes can be used. But these bites must come from periorbita behind the rim and come out anteriorly, maybe a little higher than the lateral tubercle, and then give a good firm contact so that the lateral canthus is anchored well. Sometimes we use periosteal flaps. Sometimes we even need to use holes through the lateral orbital rim. So an example of a lateral canthal reconstruction with good firm anchorage. Medial canthus repositioning again is very important, and the principle is to fixate it posteriorly behind the sac at the posterior lacrimal crest, which must be exposed well, where sutures can be placed, or you can use a low profile mini plate, which is what we often tend to do, as you see here. So an example of a medial canthal avulsion where medial canthus reconstruction was done. To conclude, eyelid repair needs to be customized based on the properties of the eyelid defect. Partial thickness defects are repaired by simple closures, flaps, or graft. Full thickness defects require adequate effort at repairing both the laminae, skin muscle, and mucosal lining with a supporting structure. But it is critical to precisely reconstruct lateral and medial canthi whenever they are involved. So a versatile combination of techniques. You always need to have a plan A and plan B, because often the planning needs to change on the table, and good adherence to basic principles is the key to success in eyelid repair. Thank you.
Thank you, Dr. Grover. That was an extremely extensive and well-covered talk, which covered each and every aspect of eyelid reconstruction. Maybe we can have the discussion after a couple of more talks. So next we have Dr. Fairuz. She is an eminent oculoplastic surgeon practicing in Bangalore and several other places, and also a scientific committee member. So I thank Dr. Fairuz for being a part of our course. She'll be talking about OSSN and how we can keep the surface safe.
Good morning, everyone, and happy to have you all here in this session. Rwituja, thank you so much for making this IC a very diverse one, including an tumor in a reconstruction IC. So I will be speaking to you regarding ocular surface squamous neoplasia. How do we keep the ocular surface safe? Interesting. So we all know that ocular surface squamous neoplasia involves the ocular surface, which is the limbus. So it is due to the, the transitional zone theory, where the epithelial, the basal epithelial cells of the limbus undergoes transformation, and there is dysplastic changes, which is extending to the cornea and the conjunctiva. So this is the basic etiology of OSSN. Now, UVB radiation is considered to be the most etiological agent, where it can cause damage, DNA damage, and there is the pyrimidine derivatives of these cells undergo proliferation, and then dysplasia, carcinoma in situ, and then it's a spectrum. Human papilloma virus is also yet another etiological agent, where even UVB radiation can cause changes in the HPV virus, activate it, and then further cause the neoplastic changes. So as you can see here, this is an ASOCT where you can see the limbus is involved, where the tumor is extending into the cornea and into the conjunctiva. So ocular surface squamous neoplasia is a spectrum. The spectrum involves dysplasia in one end, which can be mild, moderate, and severe. Then it goes to carcinoma in situ, and further to invasive squamous cell carcinoma. So we have a pre-invasive OSSN and an invasive OSSN. Now let's see how we can safeguard the surface in the management of ocular surface squamous neoplasia. I'm going to ask this question and put this question to the audience over here. So this was a patient who came for a second opinion for this lesion in the cornea. He was advised surgery, surgical excision of the lesion, keratectomy probably. How many in the audience would prefer surgical excision of this lesion? Sir, okay. Anyone else? What else do we have as an option here?
Topical treatment.
Topical treatment, yeah. So I decided that I'm going to go for a topical treatment because I want to preserve the surface, all right? Although it's arising from the limbus, most of the extension is into the cornea. So I want to preserve the cornea here. And we have excellent topical immunotherapy and chemotherapy with it, where you can actually preserve the limbal cells, the epithelial cells of the cornea, and get rid of this. So this is the ASOCT, where this is very, very typical of OSSN, where you have the snouty appearance and affecting the epithelium of the cornea. I just did 3 cycles of topical interferon in this case, and he has an amazing surface. The surface is preserved and the lesion disappeared. So in this one slide, because of the paucity of the time, I'm going to show you how the topical chemotherapy in ocular surface squamous neoplasia work from the same review of literature that we had published many years back. So the options that we have is mitomycin C, 5-FU, interferon alpha 2B. Now, what I consider when I select a drug for my patient is definitely the surface. The drug with least surface toxicity is something that I would prefer. Let me take you to the adverse effects. So with mitomycin C, conjunctival hyperemia, blepharospasm, a lot of surface toxicity is reported with mitomycin C. When you come to 5-FU, well, the surface toxicity slightly reduces. And interferon, the surface toxicity is almost nil. You don't have conjunctival hyperemia. The patient is very comfortable. The only thing that they might land up is when you inject it in a larger dose, they might have a flu-like syndrome. So for the same reason, the advantages of topical chemotherapy is no surgical compromise of the surface, less invasive modality. It causes chemoreduction, and it also can target subclinical and residual tumor cells. Now, if you ask me what is my favorite topical chemotherapeutic agent or immunotherapy, I wouldn't shy in telling my most favorite is interferon because of the less surface toxicity. And my second favorite would be 5-FU. Well, MMC in my practice, I actually don't use it anymore because of the surface toxicity. Now the cost factor, all right, yeah. So I'm going to compare United States and India regarding the cost factor of each. So 5-FU is very, very cheap. So if you see, it's like $1, all right? It's 50 rupees, less than 50 rupees a vial for 5-FU. And interferon, it comes to around 1,200 rupees in India, but well, it's slightly expensive in United States of America. $17 in Indian. Sir? Slightly more expensive, right, yeah. But it is affordable in our patients, when you compare to the surgery. Sir? Slightly more in United States. I agree, right, yeah. So this is a slide where I just want to highlight how topical chemotherapy, works in ocular surface squamous neoplasia. Now, there is definitive indications. I know that we want to take care of the surface, but as an ocular oncologist, for me, getting rid of that tumor and this tumor not progressing into an invasive, neoplasia or a cancer is very, very important. So these are the definitive indications. When it's corneal OSSN, well, you want to preserve the corneal epithelial cells, non-invasive superficial lesions, large tumors to chemoreduce, diffuse placoid OSSN, adjuvant post-surgery in positive margins. So most of the time, when a patient comes post-surgical, for my opinion, some patients are on topical chemotherapeutic drugs despite excision biopsy and a negative margin. I think that is not what we practice. If pathologically, after an excision biopsy, you can prove that the margins are negative, there is no need to put the patient on further topical chemotherapeutic agents. You're done with the treatment, but keep the patient on regular follow-up. So these are the lesions that exactly what and where I would use topical therapy for the good surface. So this was a young patient, a 15-year-old, immunocompromised HIV, where she came with this lesion with lots of keratin over here. She has been treated on steroids, but the typical keratin over the surface says that it's a diffuse OSSN in an immunocompromised patient. The only thing that I did was topical interferon alpha 2B therapy, and this is 6 months post-treatment, and she is disease-free for the past 7 years. Now, we can have multiple lesions, okay? So these are 2 foci of OSSN in the ocular surface here. Excising this would be a large excision, right? Including both these. So again, what I did was injection, intralesional interferon alpha 2b and topical interferon alpha 2b. So in my practice, I most of the time add intralesional because the resolution is more quicker. Just with topical interferon, this might take like 6 months or 8 months, but if I inject, trust me, 3 months you can find complete resolution of the tumor. Now, again, lesions like this where, you have to make sure that it's not invasive. Clinically, how would I make sure is with a cotton bud tip, I would try to move the lesion. If it is fixed, then that means there is some amount of invasion. But note that at the limbus, most of the lesions are fixed. I'm talking about the conjunctival side, all right? And of course, ASOCT will help you with that. Large lesion like this, and these are all intralesional interferon, topical interferon, 3 months of treatment with combo. This patient was referred to me as query conjunctival melanoma because of the pigmentation. So in pigmented population, like Asian population, African population, you have a variety of pigmentary form of OSSN. So this is actually OSSN. You can find this papillary fronds over it, all right? And in fact, when I looked into the other eye, all right, he had a small corneal OSSN also in that corner. So what I did was I injected the left eye, which is the diffuse one over here, and topical chemotherapy for the right eye. And he was socioeconomically quite backward. He didn't have a refrigerator. He was a farmer at home. So I couldn't give him topical interferon alpha 2b because it requires cold chain, maintenance of cold chain in a refrigerator. So what I did was put him on topical 5-FU for that reason and intralesional interferon. So it's a combination of 2 drugs over here taking care of this patient. As I told you, a combo of intralesional and topical chemotherapy can reduce the resolution. As you can see here, it's just 5 weeks for the resolution of the tumor. Now, a diffuse lesion over here, how would I go about that? Is I would take map biopsies and prove that where are the regions where the tumor is positive. She has tarsal involvement, caruncular involvement, superior tarsal involvement, and the conjunctiva was involved. All these were positive. So how do I do an intralesional injection? This is kind of a diffuse situation. In focal one, close to the lesion, away from the lesion, I would inject into the lesion, but this is very diffuse. So what we do is inject with a 30 gauge needle, causing a diffuse ballooning of the conjunctiva. I would also go intratarsal and a cryotherapy because she had an eyelid margin involvement. And well, voila. This is how she is with this diffuse involvement. So the surface has been preserved here, avoiding extensive surgery in here. Now, there are certain situations, well, of course, invasive squamous cell carcinoma. This is an immunocompromised patient. This is immunocompetent patient, where surgery is the gold standard. If it's invasive, well, no chemotherapy, topical, no immunotherapy. Now, even while doing surgery, we have certain steps that we take care so that, again, the surface is very well preserved. So taking a margin, a 4 millimeter margin all along the lesion in order to get a free margin in histopathology to reduce the recurrence is very, very important. With the free margin, the recurrence is less than 3%, whereas with the positive margin, the recurrence is as high as 35%. Now, this patient had an invasive squamous cell carcinoma, so there is a sclerectomy which is being done, and this is keratoepithelectomy which is being done. In cornea, we go 2 millimeters around the lesion, so the entire lesion is separated, and from the limbus, where the origin or the pinnacle of the OSSN is, we kind of resect it. Well, a meticulous dissection is very important, and then cryotherapy is something that we do, which is so very, very important, double freeze thaw cryotherapy. And taking care of the surface is with amniotic membrane graft, and this is applied with a tissue glue. All right, so this is just a brief overview, margin clearance, complete excision, taking care of the surface with amniotic membrane graft, and cryotherapy. So this is a paper which is one of my favorite. It came in 2014. In fact, we all started using interferon in 2014, where there is not much of a difference in recurrence in surgical excision versus interferon. Now, after excision biopsy, this is an AMG well kept, well in place, we can have histopathology showing that there is base positivity, where there is, the tumor cells are in the base. So the treatment doesn't end there, right? So we give a plaque brachytherapy for the surface. So for the margin, if it's positive, it's topical chemotherapy. If base is positive, then we give a plaque brachytherapy. Now, giving plaque brachytherapy to the ocular surface, the dosage that we use is around 4,000 to 5,000 centigrade. It's not harmful for the surface, so this is how the surface looks after plaque brachytherapy. So concluding, topical chemotherapy is non-invasive. It preserves the ocular surface, especially in corneal OSSN and non-invasive OSSN. It's excellent in outcome, and primary wide surgical excision is the gold standard in invasive squamous cell carcinoma. Well, amniotic membrane graft has to be used for surface reconstruction for a safer surface. And plaque brachytherapy in invasive tumors, well, it is definitely safe for ocular surface, as you saw in that case with the amount of dosage that we give for radiation. So thank you, Rwituja. So we share a good bond, a sisterhood bond, and you have been doing excellent job as an upcoming oculoplastic surgeon and oncology. So it's a pleasure being here today. Well, I also would like to remind you, we have the International Society of Ocular Oncology, which is coming up in December in Goa. It's an international conference. So I request and invite all of you for this conference. Thank you so much for your patient listening. Thanks.
Thank you, Dr. Fairuz. And indeed, it was a mesmerizing presentation because it covered each and every aspect with such a good variety of cases. So it was a treat to watch. And I think all of you have got a lot of learning from this, especially on when to use topical therapy, when to go in and do surgery, how to image, and how to decide on treatment. So she's the authority. So thank you for that.
Thank you, Rwituja. It's a pleasure. Thanks.
So last and certainly not the least, we have Dr. Sharon D'Souza, with whom I share not one but two alma maters. And she's another authority on surface, a meticulous surgeon and a great teacher and a great orator. She'll be talking about ocular surface cicatricial disorders and how best to use the MMG. Over to you, Dr. Sharon.
Thank you. Good morning, everyone. Is this on? So it is absolute pleasure to be here in your course again, Rwituja. You've been doing great, as everyone has reiterated. But more importantly, before I start my talk, I'm so happy to hear things like, we're going to save the surface, we're going to save the cornea. I'm predominantly a cornea surgeon, so it gives me great joy when everyone's worried about the cornea and the limbus. The mucous membrane graft has really saved us in a number of situations. And before we see how and where we could use it, it's very, very important to understand an abnormality of the ocular surface. We understand how a normal ocular surface looks like. And this may seem very basic, but there are certain things which we take for granted, including the direction of the upper and lower eyelashes, the lid margin, the luster of the ocular surface, but be it the cornea or the conjunctiva, and the tarsal surface of the conjunctiva. So, and the caruncle, very, very importantly, because a number of our cicatricial disorders, especially ocular cicatricial pemphigoid, has very early changes near the semilunar fold and the caruncle. So you can pick up these subtle changes, and you may not have to do an MMG there, but you could actually save this patient's eye by picking it up early and starting immunomodulation early. The normal lid anatomy has been beautifully covered by Sir, so I don't really need to go into it. But next time you're looking at a patient, please do go ahead and look at the normal anatomy. And do remember the MCJ, the mucocutaneous junction, normally takes up this very fine staining. So it's not an abnormal thing. The lid viper epitheliopathy, which we see, is actually a much thicker staining, and that shows that it's been rubbing on the ocular surface. But understand the normal lid anatomy is very, very important. So what happens when we have an abnormality of the mucocutaneous junction? So that line which was running on the lid margin now gets posteriorized. It's gone onto the tarsal surface. And in addition to the change in position, it's also significantly rougher, because now it is a keratinized epithelium which has come onto the tarsal surface, and that is what is rubbing onto our cornea and conjunctiva. So here you can see very clearly that white deposition is the keratin. and it has gone a lot onto the conjunctival surface. So obviously, this is going to cause a lot of abrasions on the cornea and ocular surface and is a problem. So the most common reason for having this much of keratinization on the lid margin is definitely Stevens-Johnson syndrome, which is an idiopathic allergic reaction which people have to various medications, or rarely an exanthematous disease. And in the chronic sequelae of the disease, we can get this kind of keratinization and, of course, other changes on the ocular surface. But here we're talking about primarily where we can use the mucous membrane. So just having the keratin is not the problem. When you see changes on the cornea and ocular surface which are attributable to that lid margin keratopathy. So what do I mean by that? If you see staining on the cornea in a particular location, say on the inferior part of the cornea, and you also find keratin exactly corresponding to the same area, then you understand that it is actually attributable to the lid. However, if you see a very diffuse staining all over the cornea and there's only a very small area of keratin or no keratin at all, there's probably something else happening there which is causing the changes on the cornea, and that patient will not benefit by doing a mucous membrane graft. And this is very, very important to understand. Not all patients of SJS require having a mucous membrane graft. So okay, now we've decided that there is lid-related keratopathy, and we showed what we are understanding by lid margin keratinization. So ideally, a patient who will do very, very well with a mucous membrane graft is someone who has a fairly decent tear film. Now we know all these patients are going to have some amount of dry eye, but a bone dry surface probably has an overlap between lid-related keratopathy and non-lid-related keratopathy. So you will have to address both. And usually for non-lid-related keratopathy, which is usually due to the dryness on the surface, we have to use other means like a scleral contact lens or something in addition to the mucous membrane graft. And the reason it's important to understand this is because we have to counsel the patient accordingly, that they would require multiple things to be done for them, and otherwise they think this surgery is the be-all and end-all, and after this they're going to become normal and everything's going to become okay with their eye. So ideally, if you have an eye which is wet, they're going to do fairly well. And of course, very importantly, you have to differentiate between atrophic meibomian glands and the keratinization which you saw. So you remember the photograph of the keratinization. Atrophic meibomian glands just look like you can see the meibomian glands, but they sort of start to fork, have a completely different anatomy. So that's not keratinization. When we are planning a mucous membrane graft on the lid, rule out any other differential diagnosis. And the primary differential that we want to rule out is something like an OCP, because that is not a condition where you want to jump in and do an MMG without the patient being completely well controlled with a systemic immunomodulation. Of course, with SJS, they have the classic history. Even if they do not know the inciting drug, they would have the history of what has happened there. And as I was saying, the fluorescein staining to see the attributable lid-related keratopathy. What is the ideal source of our mucosal grafts? We want to take any site which has a non-keratinized epithelium, and the most common site that we take it is the labial mucosa, and the most common among that is the lower lip, because we have ease of access and there's a lot of tissue which we can take very well. And even if you take a large graft which requires for like 4 lids, you would still manage to close that area and without causing any scarring or distortion of the lip anatomy, because even in spite of all their problems, many of them are still very concerned about cosmesis. Preoperative prophylactic antiseptic mouthwash is not mandatory. I do practice it in with my patients, but I know a lot of clinicians who would not. So unlike something like an osteodontokeratoprosthesis where it is mandatory to do it, here it isn't. But these patients do have a lot of oral hygiene issues, so you're taking a graft, you don't lose anything by doing a little bit of due diligence there. It can be done under a general anesthesia or a local anesthesia. I would think that, recommend that if possible, please do it under a general anesthesia. It is much more comfortable for the surgeon and for the patient. However, I do most of my cases under local anesthesia because many of these patients, because of their potential risk for allergy, do not get clearance for a general anesthesia. Our hospital is a standalone eye hospital, so our anesthetists prefer not to do it. So in that case, then you could do at maximum 2 lids. You cannot do 4 lids at the same time under a local anesthesia, it is really very traumatic for the patient. So 2 lids is possible under local anesthesia. A few things that you need to do differently. For any of you who are doing the MMG, you realize that when we are taking the graft from the mouth, there will be a lot of bleeding, even though we do infiltrate with lignocaine with adrenaline, but there will be a lot of bleeding. When we're doing it under general, when the anesthetist is putting the ET tube, they do packing around the tube to make sure that there is no blood which tracks down that the patient may aspirate when they are extubating. However, when we're doing it under LA, we cannot put a throat pack because the patient will gag. So what you have to do is put 3 strategic gauze pieces, 1 on each buccal mucosa pad and 1 under the tongue, and be very careful about the suctioning so that hardly any blood flows down. So your assistant has to be a little more proactive on that suctioning, and this works extremely well. And of course, you're infiltrating with the lignocaine adrenaline. So let's come to a few cases. This was a lady, a young girl actually, who had Stevens-Johnson syndrome a few years back. And she came in with severe photophobia, difficulty in opening the eye. And she did know the drug, but it doesn't matter to us that much. One thing you must be very sure of is that it is not an active disease, because that is not usually the time to intervene for doing this, unless there is an emergency where you have a perforation or a melt. Wait for it to quiet down. Unlike conditions like, again, OCP, which have a very, very tumultuous course, Stevens-Johnson's in the acute stage for most of them is low and then is very high and then settles down. So obviously you can see the amount of scarring and vascularization there, and this is a classic keratopathy, which we are trying to identify, and with the amount of lid keratinization, we now understand this is a lid-related keratopathy. So this patient underwent a mucous membrane graft, and you can see that now we have a beautifully placed graft, and the surface is smooth, and the edges are well-rounded. So this is the kind of clearing which happens just by doing the mucous membrane graft. There is no procedure which has been done on the cornea, but just by removing the inciting agent which was rubbing on the cornea clears significantly. And this is probably, the first day post-op, even though it sounds like such a traumatic surgery where you're taking something from the lip, stitching it onto the lid, but the patient's eye opening improves from day 1 without a topical anesthetic. And that's when you know that it's actually helping. Even with the edema there, they are much more comfortable from day 1. Very quickly, I'm going to just run through the steps. So the first thing is, of course, to retract the lid. We take about a 20 mm on the lid margin length. So even if you see that it's a smaller area of keratinization, it is advisable to do the MMG for the entire lid margin, because at some point they're going to develop it, and if you leave a section out, you will have to go in and repeat it. So you measure that out. Mark, okay, this is not playing. Yeah. You take the incision, you can't really see the MCJ in most of these patients, and even the meibomian gland openings are lost due to the amount of scarring there. So you can take it just behind the lid, the lash line, and try to include as much of the tracheitic lashes that are possible. So you can see the buds which are there under the eyelid, and that helps very well to make a tamponade. So the amount of bleeding, as you can see, is extremely little. The minute I release that, it will bleed. So you just keep. So the first incision is a little vertical, and then you go more horizontal to go on top of the tarsal plate. You want to avoid damage to the tarsal plate because your meibomian glands are in there. If it's very friable, sometimes you may do it. And that is the tarsal plate which is exposed, as you can see. So usually we would remove about 4 to 5 mm. Okay, and the same thing is repeated for the lower lid. I do not do the buccal mucosal dissection, the labial dissection through a microscope, so this is a little blurred. But basically, you have to take for 2 lids from the same graft. So this is a 20 by 10. We've already infiltrated. Mark out your area which you have to dissect. And then the dissection is very simple. Do not go too deep for 2 reasons. One is it will bleed much more. And secondly, you have to thin out these grafts so your work increases significantly if you take a very deep graft. But you don't want to buttonhole it, so if nothing, you can take a thick graft and then thin it out. So this is a process which is very, very important. So I'm done. Very, very important. You have to thin out your grafts. You do not want a bulky graft sitting on the lid margin because you'd potentially worsen things out. So you just have to roll it around your finger and then sit and patiently remove of the fat. Okay? The suturing is a mattress suture along the side, so you suture along the lid margin and glue the remaining part. So the right eye was the one which was operated, and they have extremely good opening, as I said, just immediately the day after surgery. So if you do not have, the upper lip has already been, the lower lip has already been taken, you can always take a graft from the upper lip as well. So that's not a problem. And they do extremely well post-operative. For those of you who are interested in learning about it, there's an excellent paper which has been published by Swapna Shanbag and group from LV Prasad, and it really gives a very nice step-by-step understanding of the lid margin mucous membrane graft. Before I close, I just want to highlight that there is one other indication where mucous membrane grafts are very, very useful, and that is when we place them on the bulbar surface in cases which have very extensive symblepharon for initial shortening, so for some amount of reconstruction. However, there, again, you have to thin it out extensively because otherwise you'll have a bulky surface there. So that's also, it's a totally different talk, but that's also extremely useful in our ocular surface reconstruction. Thank you very much for your patient listening. Rituja,
Thank you,
a pleasure
Dr.
as always.
Sharon.
Sir, thank you.
Thank you so much, and I think it was really good that we had a cornea surgeon amongst us to educate us on how the MMG works for the ocular surface. So from fascia lata to skin grafts to mucous membrane grafts and AMGs and the MMG, I think we've covered everything with respect to reconstruction and how to pull in flaps and grafts. So thank you very much, and I won't overstep into the other courses time. So thank you everyone for this wonderful course, and I thank all my co-instructors for taking part. Thank you.
She messaged me.